Let's see. We should be starting to record. I am Dr. Brown, and this is our case review series. Um, Good morning, everybody. Just want to mention the two books that we use are Case File Psychiatry by Toy and Clement, and Psychiatric Case Studies for Advanced Practice by Prendergast and Jackman. Today, we're going to be discussing a case out of the Psychiatric Case Studies book, and we'll be talking about ODD, Oppositional Defiant Disorder, and ADHD unspecified. This will be case number case number 6. Uh, I think y'all have requested uh, a pediatric case study, so we'll jump into that age range. The name of this case study is Not Cooperating and Being Aggressive. Um, Identification: the patient's a 12-year-old white male who's in the seventh grade and he lives with his parents and a 7-year-old sister. The patient was referred to outpatient child and adolescent and family center. Um, the chief complaint, according to his mom, is quote unquote, my son's aggressive behavior is now out of control. History of present illness. The parents report that the patient has been a good student, receiving C and B grades over the past years, but in the last 6 months, his mood has become irritable and angry at home. He has been having physical shoving matches with his little sister that end up with her crying, and the patient has to be disciplined. He has been easily annoyed by anything his parents say to him, causing arguments with his parents and blaming them blaming them for his annoying behavior. Um, let some more people in. Uh, um, the teacher reports that he's been much more argumentative with her in math class, and at times he disrupts the class. Um, the science teacher also reported one episode of him being verbally aggressive with a student in his class last week. Past psychiatric history: the mother reports that her son's behavior is somewhat a problem was somewhat a problem during his early kindergarten period. He did not like going to school. He would protest, and then he would become aggressive with the other children, taking their toys, shoving and hitting them if they did not respond to his request. His mother indicated that during this time, the patient would be mean to a small dog that they had adopted, and he would kick the dog when he walked past him. Both the dog and the patient had to be separated. The father would often become enraged and and scream at his son about what he was doing. He would be placed in timeout for 15 minutes, which would sometimes work, and at other times he would go back and try to kick the dog again. Um, the pattern of behavior came so bad that the parents had to go in for parent counseling to get their anger under control and to learn how to manage their son. During the early years, the child was also evaluated by a child psychiatrist who diagnosed him with ADHD and recommended that he be started on a psychostimulant at the age of 7. At at the time, the parents reported that they were fearful that he would become addicted to the medication. Uh, and according to his parents, he was doing very good at that time, getting good report cards. So they opted not to start the medication. Medical history: he had a history of tonsillectomy at the age of 6 from chronic streptococcal infections. Um, I believe that's just a bit of a red herring. We can talk about that later, but sometimes when kids have strep infections, they may develop an antibody that may cause um, chorea, abnormal movements, and that's sometimes associated with obsessive OCD type behaviors. Um, History of drug and alcohol abuse. These were denied. He's just a 12-year-old. Um, Family history: the mother reports that she married her husband 15 years after they attended the same college. The mom works as a high school math teacher in a local high school. The father is an engineer for a large aeronautical corporation and travels at least 5 days each month. Uh, they have a 7-year-old daughter who's in the second grade and is doing well. The mother reports that her mother, or the patient's maternal grandmother, had been treated for major depressive disorder, and that the father's father is his paternal grandfather is recovering from alcohol use. Both families are close and visit with each other on a weekly basis. They attend the Methodist church each week, and both children attend weekly Bible study. The family is active in the community and does charitable work each month, and this does include both kids. So let's look at the personal history of the child. Um, um, Perinatal, the mother reported that she did attend a prenatal clinic for care and that her son weighed 8 pounds and 1 ounce at birth, and had obtained all of his developmental milestones at the appropriate times. As a child, the one area in which the child was slow was his speech and articulation, for which he was sent to speech therapy at the age of 3. It was continued until he entered kindergarten. He did not attend nursery school and did have some trouble adjusting to kindergarten, where he was aggressive and had anger control problems. Because of the parent counseling that lasted about 6 months, both parents feel that they've been able to manage the patient's behavior well until about 6 months ago, when the aggression and the irritability started out of nowhere. His grades in elementary school were good, with B's and C's being the average. He is active in sports. He plays tennis each Saturday and also plays the piano with a local group of friends. As far as his trauma and abuse history, the child denied any abuse by his parents, but did report he felt that one of the children at his school was becoming more verbally aggressive toward him about his outside activities and was making fun of him in front of his peers. Let's look at the mental status exam. The appearance: the child is well groomed. He's short and thin for his stated developmental age. Behavior and psychomotor activity: he's cooperative most of the time. He makes good eye contact with the examiner. He had difficulty sitting and fidgeted with a book he was reading and kept turning his head um, to look out of the window. Consciousness: he's alert. Orientation: he's oriented to time, place, and person. Um, his memory is intact. Concentration and attention: because of his fidgeting, he was distracted by outside activity and needed to be redirected back to the topic at hand. Um, Visual spatial ability was not assessed. Abstract thought: um, it was intact and assessed by Proverbs. Um, his intellectual functioning was above average. Speech and language: speech was normal rate. Um, volume with no problems with articulation. There were no abnormalities reported with perception. His thoughts were goal directed. Um, on thought content, he was concerned about why he needed to be here, and he was angry at his parents for bringing him to the appointment, but he denied any suicidal or homicidal ideation. His mood was anxious and angry, and reports that um, he can get very angry at times. His affect was congruent with his mood. His own impulse control was good. He was able to reflect on his uh, angry behavior without becoming agitated. Uh, he was aware that his parents were trying to help him in spite of his anger, and was able to understand that he was coming in to see the nurse practitioner to get help for his anger problem. So it appears that this kid has a fairly good bit of insight about his behavior. It's not automatic. Um, um, he can, he's able to reflect upon his situation, um, and he has pretty good intelligence, but he does have some fidgetiness and difficulty with staying on task. But he does have some insight into his anger and moodiness. So we're going to formulate the diagnosis, and I've already told you guys what it is, but which diagnosis should be considered. We have two diagnoses here: oppositional defiant disorder with moderate symptoms, and we have unspecified attention deficit hyperactivity disorder. Does anybody have any questions about those two diagnoses being picked before we dive in? Alrighty, then we'll just dive into the primary diagnosis, which is ODD. ODD consists when there's a pattern of angry, irritable mood, argumentative or defiant behavior, or vindictiveness lasting at least 6 months, as evidenced by at least four of the symptoms from which from any of the following categories, and is exhibited during an interaction with at least one individual who is not a sibling. And I'll go over some of these symptoms. Um, they often lose their temper. They are often touchy and easily annoyed. Uh, they are often angry and resentful. They often argue with authority figures, and if they're children or and adolescents, these are adults. They often argue with adults. They often actively defy or refuse to comply with requests from authority figures or with following rules. Six, they deliberately annoy others. Seven, they often blame others for their mistakes or misbehavior. Eight, they have been spiteful or vindictive at least twice in the past 6 months. So these are the eight symptom sets, uh, and they need to have at least four of them. That's criteria A. Criteria B, the disturbance in behavior is associated with distress, is associated with distress in the individual or others in his or her immediate social context. So they have problems in the family, their peer group, or with work colleagues, or it impacts negatively on their social, educational, occupational, or other areas of functioning. And criteria C, the behaviors do not occur exclusively during the course of a psychotic, substance abuse, depressive, or bipolar disorder condition. Also, the criteria are not met for the are not also criteria are not met for DMDD, which is disruptive mood dysregulation disorder, and we'll talk more about that disorder uh, in a minute. So, and we basically have kind of established a differential diagnosis for this condition: um, bipolar, DMDD, no DMDD, um, and there's a few others that we'll talk about in a minute. Um, so, what is your rationale for this diagnosis? All right, for the diagnosis of ODD, oppositional defiant disorder. This patient has had aggressive behaviors in school and at home for over 6 months, with anger at parents and teachers, having arguments with teachers in both math and science class, blaming his teachers and his parents for his angry and irritable behavior, being easily annoyed with teachers and parents, causing an angry outburst. Further, these behaviors have occurred at least once per week for the past 6 months. Um, he meets the criteria for moderate severity in displaying these behaviors in at least two settings. Therefore, he meets the criteria for oppositional defiant disorder with moderate symptoms. Anybody got to have any questions about the diagnosis of ODD based upon his history? All right. Um, we'll go on to the secondary diagnosis, which is unspecified attention deficit hyperactivity disorder, which would be ADHD, NOS, not otherwise specified. So this category applies to presentations in which symptoms characteristic of ADHD that would cause clinically significant distress or impairment in social, occupational, or other areas of functioning predominant, but they don't meet the full criteria of ADHD or any of the other neurodevelopmental disorders. The unspecified ADHD category is used in situations in which the clinician chooses not to specify the reason that the criteria are not met for ADHD or any other neurodevelopmental disorder, and in which there's insufficient information to make a more specific diagnosis. Now, in this case with this guy, n- I it'd be you'd be a little hard pressed. He does have ADHD symptoms, and in this case, we're actually going to go ahead and address those symptoms, even though a formal diagnosis is not made. But we see that that he's fidgety, he's distracted, uh, he's distractible, and using a psychostimulant may actually help improve his outcome. And that's generally the case in most of the children I've seen. And then most times they have ODD with ADHD. Uh, um, and we always put them on a psychostimulant. And I'm sure y'all have probably seen the same thing. Sometimes they may not even have a formal diagnosis at all of ADHD, and there may not even be that much symptomatology. Um, but we go ahead and try the psychostimulant just to see if it improves the situation. So the rationale for this diagnosis of unspecified ADHD is that the patient currently presents with hyperactivity. He had difficulty sitting still and fidgeted, and he had also had distractibility, in which he was distracted and kept looking out of the window during the interview, which comprised some of the symptoms for the criteria of ADHD. In addition, the patient was evaluated for ADHD by a psychiatrist who recommended starting a psychostimulant in the past. So there is a likelihood that the patient is diagnosed or does have a diagnosis of ADHD, but there still is insufficient information to make a specific diagnosis. And once again, ADHD is really tough. I usually diagnose it performatively because you're never really there to see the full symptom set. Um, I just do a trial of a psychostimulant for a week and get an objective observer uh, to do a pre-trial analysis using some type of scale, and then a post-trial analysis to see if there's been some objective improvement. Um, and we'll go on to some tests or tools that can be used to do these various analyses. So um, there are three tests that are presented here. One of which does address the ADHD symptoms. But the first is the child behavior checklist. the CBCL. Um, it's a parent and teacher form, and it should be used to screen for diverse areas of behavioral problems, and can be used as a baseline for treatment planning. So using this checklist, you can capture any symptoms of the ODD. The second is the bus Perry aggressive aggression questionnaire. The BUSS Perry aggression questionnaire. It can be administered to evaluate the physical and verbal aggression, anger, and hostility in a child. It can be used for children who are school aged and older. And the third tool used in this case was the Vanderbilt ADHD depression diagnostic parent rating scale. This is just the Vanderbilt scale. It can be considered. Um, it should be considered because the patient has already been diagnosed with ADHD, but it's untreated. The patient's untreated, so you can get both baseline and clinically treated analyses. Um, it can be used to determine a baseline against which treatment progress can be measured. So you have the three skills in this case, two of which apply to the ODD symptoms, the child behavior checklist and the bus pair aggression questionnaire. And then you have the Vanderbilt scale, which can be used to assess the um, ADHD symptoms. All right. So we have what differential diagnosis should be considered. We talked about some. The main one is disruptive mood dysregulation disorder. This should be considered. Um, but the difference in ODD and DD is that ODD, um, the symptoms are very similar, but they're a little more intense in disruptive mood dysregulation disorder. They're basically daily and it has to last for at least a year. Whereas an oppositional defiant disorder, uh, they're more weekly symptoms. They come and go. They're not as consistent. And uh, with ODD, they only have to last for 6 months. So those are the main takeaways between these um, two conditions. Does anybody have any questions about oppositional defiant disorder versus dysregulation? I mean, disruptive mood dysregulation disorder, because that will be the kind of the issue that may come up at hand. Does anybody have anybody that's diagnosed with DMDD on the call? Does anyone have any child diagnosed with ODD on the call? Nobody? Let me see.
Yes.
All right. So you have a patient. Which one? Which diagnosis? ODD or DMDD? Hello. I think you
ODD.
mean ODD. And how is your child being treated?
Well, the child present also with sleep issues, so I'm treating with guanfacine and as well as I added clonidine, and it's helping.
What was that again? I'm sorry, I missed you. What was the last few last
Guanfacine,
guavazine? All right.
yes,
And does he? You said he had in addition to having an ODD, he had what was the additional diagnosis?
trouble sleeping, trouble
Trouble.
sleeping.
All right. So using the guavazine to help him get some rest, help him or her get some rest.
Yes, but it's also helping the little aggression and the behavior as well.
Gotcha. 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 Um, do you think the diagnosis of ODD is spot on, or do you think there's some other considerations in this case?
I think it's spot on.
Gotcha. All right. Right. Yeah, and that treatment regimen is fair. I mean, there's, we'll keep reading. There's no real specific pharmacotherapeutic
Right?
intervention. Hello?
Yes. Hello.
Yeah, there's no specific pharmacotherapeutic intervention for ODD. A lot of it is just parent training and have teaching the parents how to deal with the behaviors. But you just always look for the associated symptoms. Now, some of the areas around ODD are how ODD can evolve. There are various and sundry. We talked about ADHD. We talked about DMDD. There's also juvenile bipolar symptomatology, which is a lot more intense, and it looks more like the regular bipolar symptoms. The patients have, periods of mania and depression. There's also childhood depression that could be look like ODDD, but obviously it's the mood symptoms are there, and there's some neurovegetative findings that are more consistent with depression. Um, and then there's also uh, conduct disorder if the child's a little older in their late teens, and we always see where the ODD kind of can be a precursor to conduct disorder and or uh, antisocial personality disorder. There's kind of that linkage going on. So there's a lot of different things that ODD can become or maybe a precursor to or look like. So you just need to keep that hat on and looking at all these other symptoms and follow these children as best you can and treat them, pharmacologically for whatever symptoms you think um, um, are there that may be associated with another one of these diagnoses. Uh, so let's go um, into formulating a treatment strategy. So, what treatment would you prescribe, and what is the rationale? Number one here was consultation with a school counselor to explore the patient's concern about being bullied. Bullying is a big thing these days, and that's one of the number one things we gotta intervene with before the problem with the child becomes a lot worse. Um, so talk to the school counselor, address the issue of bullying, and I do believe they have special therapies in school for both the perpetrators and the victims of bullying. Secondarily is psychopharmacology. In this case, we're going to start methylphenidate ER, the ER formulation at 18 milligrams a day. I think this is just Concerta, and it may be increased by 18 milligrams each week with a maximum dosage of 72 milligrams a day. Methylphenidate is approved for ADHD and has been demonstrated to be effective in numerous trials. Once again, this methylphenidate will not address the the um, the symptoms of the ODD, but the distractibility and the fidgetiness that the patient has may be improved. Now, let's say this kid did have a mood disorder, a bipolar. What do y'all think that giving this kid a stimulant will do in that case?
Intensify the symptoms.
Pardon me?
And some I've seen intensify their symptoms. Make
Exactly. They may become more they may become more moody. So sometimes by giving them a stimulant, you can determine where along the scale of ODD they're on. They may actually have some type of form of mood disorder, and putting them on the stimulant can actually, worsen those symptoms. So you'll know what you're dealing with. at that point. Um, Diagnostic tests, in addition to the routine laboratory test, an EKG should be ordered to rule out any underlying cardiac comorbidity, and this is specific for uh, you know uh, putting someone on a stimulant. And regular monitoring of height and weight should be done at each visit to ensure consistent growth development, given the current underweight status. So this kid is already little and thin. We're putting them on a stimulant which causes anorexia and could slow down, their performance on the growth chart. So that needs to be tracked. Um, um, the patient should be referred to a hearing evaluation. I guess that's just a standard intervention for someone who may be having some behavioral or performance problems in school, just to make sure that their hearing is fine. Um, Psychotherapy is recommend parent management training. It has been validated as a method to help parents better manage disruptive behavior, um, and oppositional behaviors. Psychoeducation: the parents should be provided with literature available from the American Academy of Child and Adolescent Psychiatry, um, on the safety of psychostimulant use for ADHD, and assist them with their fears and anxiety about using this medication in their child. I think the parents stated that they had a fear of the child becoming addicted or having problems with using stimulants. Also, using a parent workbook to help improve parenting skills is also considered a supportive measure for families struggling with ODD. Um, um, what standard guidelines would we use to treat or assess this patient? Well, they have practice guidelines from the American Academy of Child and Adolescent Psychiatry. The practice parameter for assessment and treatment of children and adolescents with oppositional defiant disorder, and this can be retrieved from uh, the Journal of Adolescent, um, um, or the journal from the American Academy of Child and Adolescent Psychiatry. Clinical note that they end up with here is that with children and adolescents, a special issue relevant to the assessment is the child's involvement in bullying. So they come back to bullying in this particular case as either a victim or a perpetrator. Such interactions may serve as an additional indicator that the child's functioning is impaired. So they really make note of bullying in this case, and um, if you get any report of that, definitely make sure that those issues are addressed, um, as this could complicate or aggravate the child's condition. Um, at this point, are there any specific questions about this case uh, or the diagnosis?
Hey, Russell, it's
Yeah.
Debbie.
Uh-huh.
And so, you're at the other end of the age spectrum from me in this case review. At what point would pharmacogenetic testing become a consideration in kids?
Oh, for testing to see what medication would or would
Yeah,
not
I
work.
mean, they're early in their tenure of psychiatric illness, and so is it earlier to find out the genetic spectrum of their, you know, uh, profile, genetic, psychopharmacogenetic, its early profile? I don't know. In adults, we do it.
Yeah, I mean, it's according to what medications you're going to be using. I would say in the stimulant class, since they're all roughly about the same, it may not be as important. Since
Mhm. Yeah.
one of the main agents we're going to use is stimulants, and I, like I said, I use the stimulants diagnostically. One, to see if they really have ADHD. Two, because if they get better, then you're dealing with that type of disorder. If they're getting worse, then they have a mood disorder. But if
Right.
they're gonna have a mood disorder, and you have to move over to the antidepressants and the mood stabilizers, at that point maybe getting some of the pharmacogenetic testing may make sense,
I
because
guess that's kind of where I was at. If you're looking then at beyond ADD, ADHD into the mood disorder spectrum, so if you gave them some methylphenidate and they had a manic episode, that might qualify as diagnostically as a mood disorder.
because I'm going to start treating them like that, and
Mhm.
I'm going to go back and review uh, my history and bring the parents back in and start asking questions more about mood disorders and mania and hypomania and depression, and dig deeper.
Oh yeah, I mean so just saying I do a lot of family history going back to grandparents and whatnot, or aunts, uncles, things like that. And
Mhm.
sometimes that can help you sort it out.
Yep, exactly. And this kid here did happen to have a history of mood disorder and substance alcohol abuse in the family, which would lend itself to that. But
Mhm.
um, he hadn't been treated with the uh, concerta yet, so we don't know what his response is going to be. But there's
Sure.
a chance that he could have become more moody, and then we'd know that there's some a history of mood disorder going on. And at that point, you could look at your pharmacogenetics, or you would just start, testing various medications to see how they would respond.
Let me
And
ask you, when you then if you were going to initiate treatment for a mood disorder, we'll call it bipolar in a young person like this, what would be your first line mood stabilizer?
yeah, I do have a case here that addresses that, and I was going to bring that up.
Not that I'm going to be seeing anybody less than 20 anytime soon.
Right. Let me see if I got some official information about that. All right, we got a case.
Thank you.
Um, right. All right. It says, I'll just read some of the pearls.
Sure.
Um, the American Academy of Child and Adolescent Psychiatry practice parameters hold that all the DSM-5 criteria, including the duration criteria of 1 week of for mania and 2 weeks for depression, should be followed when making a diagnosis of mania or hypomania in children or adolescents. So you have to strictly stick with
Hmm.
that same guidelines.
Timelines, yeah.
The majority of AACAP treatment guideline panel the majority of the AACAP treatment guideline panel recommended lithium
Uh-huh.
or Depakote as the first medication choice for non-psychotic mania in children. So
Hmm.
that's interesting that they'd even put lithium up there for kids. Um, there's a high degree of psychiatric comorbidity in bipolar disorder in childhood, and mood state stabilizing agents have a significant risk of teratogenicity. But um,
Yeah.
obviously these kids aren't going to be these are kids having kids. That's probably not going to happen.
Hmm.
Um, so yeah, to answer your question, um, they say lithium and Depakote, so the mood stabilizers are the way to go if you think a kid like this may be more on the bipolar spectrum or having uh, some mood disorders. But yep, and I'll read down here guidelines. According to the AACAP guidelines, monotherapy with traditional mood stabilizers, lithium, Depakote, carbamazepine, or the atypical antipsychotics, olanzapine, quetiapine, and risperidol, they're the first line treatment if no psychosis is present. Um, The majority of the guideline panel, and this is in bold print, the majority of the guideline panel recommended lithium or Depakote as the medication for the choice, first medication of choice for non-psychotic mania. So over
Mhm.
and over again, lithium and Depakote are coming up in juvenile bipolar cases. So if these cases of ODD or whatever disruptive behaviors kind of evolve into that, then
Mhm.
Depakote and lithium are the two agents to go with. If the child is a lot younger, because of liver
Mhm.
situation, I'd probably avoid the Depakote and go with the lithium. But if they're a little older, um, I'd go with the Depakote. If they're younger, I'd go with the lithium. But like I said, it's really strange, you know, reading something and then thinking about using it because
Mhm.
you wouldn't think about using these medications in children so young.
Well, what's interesting to me, again, I'm not in your age group here, but I run into a good number of folks in their 20s and 30s who are bipolar who have never, quote, even heard of lithium. And it's like, wow, that they've gotten this far. And usually they're not doing well. If I get to see him,
Right,
and no Depakote and no lithium, and it's like that's pretty darn amazing.
right. It is. Yeah.
I can say as far as myself treating children, I know Abilify is where I know it says lithium depakote, but I would not on a child. I'm sorry.
I agree.
I know a small dose of Abilify has worked, and a lot of times you will see a lot of children that has been in hospitals come on Risperdal. So those
Mm-hmm.
Yeah.
like the
Mm-hmm.
big two.
Mm-hmm. Yep. Yeah. I would tend to bypass those two meds and jump to an atypical antipsychotic and just start off with that to see if it works. And if it doesn't work, then I'd go to these old gold standards. Yeah, but it's tough to put a young brain or a young body on those hard medications like that. Um,
Even in adults, Russell, who I have on lithium or who are taking lithium, some of them are on what you would consider a subtherapeutic dose,
mhm,
and their levels are clearly subtherapeutic, but clinically, it's
mhm,
working.
mhm,
Maybe 300 at bedtime, their lithium dosing, and that's it.
mhm, 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 mhm. Um, Yeah, and as far as the antidepressants, I'll just read about that. It's in juvenile bipolar,
Mhm.
off-label utilization of SSRIs and Wellbutrin can also be considered during bipolar depressed phases, based on the American Academy of Child and Adolescent Psychiatry guidelines, and lamotrigine and divalproex or other treatment options noted. Many antidepressants are believed to be able to trigger or unmask mania, so they should be used carefully, and patients should be observed closely for manic symptoms. So once again, if you got a child that's kind of bipolarish, just be careful with just using strict antidepressants in them, because you can push them into the manic phase and make the disruptive behaviors a little worse. Um, any other questions about ODD and its ramifications, what it looks like, what it can evolve into, and how it should be managed, both psychotherapeutically and pharmacotherapeutically? There's not really much you can do. You just got to kind of keep coming back to the history and seeing which symptoms kind of stick out and make a decision, whether you're going to employ a medication or not. And and the you know the the basic thing is just to make sure that the parents are involved in therapy, um, for parent training and psychoeducation. Any other questions or about this case or thoughts? Do y'all want to do another child case next time?
Yes.
All right. All right. We can do another one. I'll pick something else. I know a lot of us, because where we practice and how we practice, we end up seeing invariably, children walking in. So, and that's where the short in the market is. So, I'll do a couple of child cases, and we'll just go back and forth between children and adult cases. So, we'll be evenly yoked.
Thank you.
Any other questions? Well, hopefully, we cleared up some stuff. Um, Gave people some new treatment options, and new diagnostic considerations with these cases. Because children come in as they're just a bag of behaviors, and it's hard to kind of dissect them. But hopefully, this will help you guys out. Okay. Well, with that being said, I'm going to go ahead and sign off. All right. I'll
Hey,
talk to
thank
you
you.
guys next month. Okay.
Hey, thank you.
Bye bye.
Bye-bye.